Hi, it's Peter Millard again. Welcome to the second lecture. Like the prior lecture, this will be a combination of methods and a little bit of substance, but I think the substance you'll gain largely by reading the articles rather than listening to lectures. Again, I'm really emphasizing the interactive nature of this course and analysis, so giving you facts I don't think is going to really help you in that. I'd like to just quote from Albert Camus. If you haven't read The Plague, it's a great novel and it's a story. So I think it's well worth reading. And I think that epidemics like tornadoes, hurricanes, and all other natural disasters do have a way of recurring. There's no question that we've had recurrent epidemics throughout world history and that we're going to have ones in the future. In fact, the epidemic that we have now, the HIV epidemic, is probably the worst epidemic ever in history. The fact that it's not airborne gives it a bit different character than some other epidemics, but nonetheless, it's a very, very severe epidemic. After this talk, you should be able to uh, talk about the difference, understand the difference between measures of association and measures of impact. You should be able to calculate and interpret relative risk reduction, and number needed to treat. You should, along with the reading, be able to describe some of the important terms used in ID epidemiology. And you should also be able to describe likely scenarios for a future outbreak of influenza. In the first part of this talk, I'd like to talk about the prevention of maternal to child HIV transmission. And in order to do that, I'd like to talk about a particular landmark study, ACTG 076, which was published in 1994. This proved for the first time that AZT, the first drug we used to treat HIV infection, by itself can reduce peripartum HIV transmission. We've come a long way since the study, and we now know that multiple drugs can prevent transmission much better than a single drug. But in order to illustrate some methodological issues, I want to just take this very simple study and analyze it with you for just a moment. First of all, I'd like to talk about the two essential elements in every randomized controlled trial. First of all is subject flow. The authors of any study have to show exactly what happened to every subject who expressed an interest in participating in the study. This is very important because of the issue of selection bias. That is, that dropouts or uneven selection into the study can have effects on the validity of the study. Secondly, by convention, there's a table 1 in every study which is used to compare the baseline characteristics between each arm of the study, generally a treatment arm and a placebo arm, in order to be able to evaluate for confounding. So we're going to be talking about subject flow and confounding. This shows what is called, actually, in this particular study, ACGG 076, this shows table 1, which shows the flow. So it shows that there were 239 women that were randomized to the AZT arm and 238 that were randomized to the placebo arm. And among those women, 2 women didn't have HIV infection at all, some women withdrew, some women were still pregnant at the end of the study, and some lost their pregnancy, that is, they had a miscarriage. So that you can see that there were, in the end, there were 205 mother-infant pairs in the AZT group and 204 in the placebo group. And there was, again, some information that wasn't available for the children. So this gives you an idea about what exactly happened to all the participants in the study. Instead of showing the patient flow in tabular form as they did in the ACTG 076, these days we prefer to show patient flow in a flow chart. This is using what are called the consort guidelines, which are guidelines for the reporting of randomized controlled trials. This shows the figure 1 for a randomized controlled trial that we recently published concerning circumcision. So you can see we had 241 subjects who were eligible, that we excluded 41 of them, and the reasons for exclusion, we randomized 200 of them. Each 100 were done in the group to which they're allocated. Then we show all the loss to follow-up and what happened ultimately with every patient in there, every subject in the study. Now, what is generally called Table 1 is for evaluation of potential confounders. Now, first of all, I'd like to just review the concept of confounding, not the whole concept, but simply to say that confounding is an epidemiological, it's not a statistical phenomenon. You remember when we talked about the difference between epidemiology and statistics. Epidemiology has to do with validity or preventing bias, and statistics has to do with precision or reproducibility. So they're in Table 1, when you talk about the baseline characteristics of the participants in the study, there's little value to little meaning to the p-values. You sometimes see p-values in Table 1, sometimes you don't, but something can be a confounder whether or not there's a statistically significant difference between the two arms. This shows again ACGG 076. This should be Table 1, and in fact it's shown as Table 2 here because they use the patient flow as Table 1. But how this shows the median age of entry for the women who participated, their race, the history of injection drug use, median CD4 count, what are thought to be important potential confounders to the study. You can see that there aren't big differences between the groups. You wouldn't expect there to be big differences because they were randomized and it's a reasonably good sized study, but you're always going to see some differences, and those differences could represent potential confounding. But notice that there are no p-values in this table, which is appropriate because, as we said, confounding is not a statistical phenomenon. It's an epidemiological phenomenon. So one way to be able to decide whether, if there were differences, whether it was confounding, would be to use a model that would account for those differences and see if there's any difference in the relative risk. In general, there isn't. And in this case, I suspect there also isn't because they're very close. Proportions of women in both groups that are for all the potential confounders. This shows the results of ACTG 076. This is a Kaplan-Meier plot, which you see very frequently, and it shows the number of women who received the placebo and the AZT 183 and 180 at the beginning of the study and during the follow-up period. Of course, after women delivered and their babies were either infected or uninfected, they were no longer followed, so that you see that the number of weeks and the number of women. So at the end of the study at 72 weeks, there were in fact only 37 women in the placebo group and 43 in the AZT group. And you can see the confidence intervals for the percentages of probability of transmission. In the placebo group, there was a 25.5% probability of transmission. And if you look at that vertical line, it looks like it goes somewhere between 17 and 34%. And then in the AZT group, the probability of transmission was 8.3%. So again, placebo versus AZT, 25.5% versus 8.3% at 72 weeks. Now, just to review the concept of relative risk with you briefly, relative risk is really very, very simple. It's simply the proportion experienced in the outcome in the treatment group divided by the proportion experienced in the outcome in the control group. And remember that a relative risk of 1 means there's no effect. A relative risk of 0.5 means that the rate in the treatment group is half that in the control group. And a relative risk of 2, which is clearly not desirable in a randomized controlled trial, but is what you might expect to see if you're doing a cohort study of a noxious exposure. The rate in the treatment group is twice that in the rate in the control group. This assumes that the outcome you're looking for is something undesirable, so death or, in this case, HIV transmission. If the outcome you're looking for was somehow desirable, then the meaning of the relative risk would actually be reversed, but you'd have to just look at the context of the study to determine what exactly the relative risk means in terms of treatment group versus control group, in terms of the outcome that's being measured. So in ACTG 076, we see the relative risk is simply 8.3% divided by 25.5%, or 0.325, with a 95% confidence interval of 0.179 to 0.593. You can think of the relative risk here, the 0.325, as being the point estimate. That's our best guess for the actual relative risk in a biological sense. The confidence interval gives you a range of plausible values that if you repeated the study over and over again, assuming that the point estimate is correct, that the real biological phenomenon is 0.325, you would expect 95% of the time to have a relative risk, to find a relative risk between 0.179 and 0.593. Notice how this differs from the p-value, and we prefer not to use p-values in this case. The fact that the 95% confidence interval does not include 1, remember that for relative risk 1 indicates no effect. Since the confidence interval does not include 1, we can say that the p-value is less than 0.5, that it is statistically significant. But the confidence interval is preferable because it gives us more information than the p-value. It not only tells us whether it's statistically significant at the p less than 0.05 level, but it also gives us the range of plausible values. This is simply a graph of the same phenomenon, and the reason why I want to show you this is because if we were looking at multiple studies that examine the same question, we could list all the studies, and that's really what happens with meta-analysis, which you're going to learn about later. So since we only have one study, it doesn't make as much sense to graph it, but nonetheless, we've done that. You can see at the top, it says in yellow on the left, favors AZT. That is, if the relative risk is less than 1, it favors AZT. If the relative risk is more than 1, it favors placebo. And so we have ACTG 076 listed, the number of subjects, and then you can see the point estimate in the little oval circle, which is 0.325, and you can see the confidence interval. You see the confidence interval is relatively short and it doesn't come close to 1, so therefore we know that the result is statistically significant. The problem with relative risk, though, is that nobody actually uses relative risk when they talk to each other or when you read about a study in the newspaper, because relative risk by itself is a little bit hard to interpret. Instead, we talk about relative risk reduction. And the relationship between relative risk and relative risk reduction is very simple. relative risk reduction is simply 1 minus the relative risk, and we always express it as a percent. So again, ACTG 076, HIV transmission at 72 weeks, the relative risk reduction is simply 1 minus 0.325, which is the same as 0.675. And if we just multiply that by 100 in order to get percent, we can see that that's 67.5%. So in normal language, we would say that AZT reduces HIV transmission from mother to child by 67.5%. That's the point estimate, the best guess for that relative risk reduction. Likewise, if we just subtract each one of the confidence intervals from 1, we can get a 95% confidence interval for the relative risk reduction. So 1 minus 60% is 40%, okay? In this case, then 1 minus 60% is 40, or close to 60%, 59.3 I think it is 40.7%. And the upper limit of that confidence interval is 82.1%. Again, the confidence interval is the best guess for the plausible value. If the true relative risk reduction were 67.5% and we repeated the study over and over again, 95% of the time, we would find a result between 40.7% and 82.1%. So relative risk and relative risk reduction express exactly the same relationship. This is a simple calculation to translate between the two of them. But the important thing, I think, is that relative risk and relative risk reduction is a measure of association, and it tells us nothing about the impact of the intervention. So it tells us about the strength of the association. It's really important in terms of determining causality. But remember, when we talk about randomized controlled trials, we don't need big criteria for causality because randomized controlled trials are true scientific experiments. And so if the scientific experiment is repeated several times and finds the same result, then we conclude that there is a causal relationship between, let's say, the treatment and the reduction, in this case, of HIV transmission. So relative risk or relative risk reduction shows the strength of association, but it tells nothing about the impact. And we need a measure for impact, and we measure impact through attributable risk. It's also known as absolute risk reduction or risk difference, and I prefer the term risk difference because it's a much more straightforward term. When we talk about differences, we just talk about subtraction. So it's the subtraction of risks, or the risk difference. I apologize for epidemiology as having so many terms that basically mean the same thing, but once you get beyond that, I think it's not quite as complicated as it all seems. Okay, HIV transmission at 72 weeks. The risk difference is simply 25.5% minus 8.3%, or 17.2%. The confidence interval, 8.9%. Minus 25.5%, again, just taken by subtracting. And now this is the risk difference. The risk difference, again, is a little bit difficult to interpret. Like the relative risk, it's a nice number, but we need to just convert that a little bit in order to have a number that is a little bit easier to understand. Again, the risk difference measures the impact, and nobody really refers talking about attributable risk when we talk about randomized controlled trials. That's used more for cohort studies. When we discuss the results of randomized controlled trials, we talk about the number needed to treat. And the number needed to treat is also, again, a simple statistic to calculate, and it's the number of people you need to treat to prevent one, in this case, bad outcome. In this case, would be an HIV transmission. Okay, because generally when we do randomized controlled trials, we're trying to prevent an undesirable outcome, in this case, HIV transmission. So the calculation of the number needed to treat is really simple. It's just 1 divided by the risk difference. In this case, you remember above we said the risk difference was 17.2%. So it's simply 1 divided by 17.2%, which this time we remove the percentage sign. And it's simply 1 divided by 0.172, which is 5.8. And again, we can use a confidence interval of 3.9 to 11. So in summary, we would say in this study, you would need to treat 6 women to prevent 1 HIV transmission. Well, is that a good number? Yes, it's an excellent number. To think that any intervention that has relatively few side effects would be of that impact, I think is quite remarkable. And the impact of giving more medications, 3 drug therapy to prevent HIV transmission, of course, is very much stronger. So we can say that we would treat 5.8 or rounded up to 6 women to prevent 1, and the 95% confidence interval is somewhere between 3.9 or 4 women and 11 women. Now, the reason why that's so few is because the baseline risk was so high. The baseline risk was 25%. And so therefore the number needed to treat is very small. If we take an outcome that's quite rare, let's say 1 in 100, if you just think about it intuitively, you would say if the risk is only 1% or 1 in 100, you'd have to treat a lot of people to prevent that one case, because 99 out of every 100 people aren't going to get it even if you do nothing. And so the baseline risk is really a big factor in calculating the number needed to treat. And in this case, the number needed to treat is very low. But for many, many interventions in medicine in which the baseline risk is lower, the number needed to treat is much higher, which is very appropriate. And it depends a lot on the outcome, or sorry, on the side effects of the treatment and the cost of the treatment. If the treatment has a lot of side effects, it's dangerous, it's expensive, then you want the number needed to treat to be much lower than if the treatment were cheap and easy to take and had fewer side effects. So you can't really say, well, one number needed to treat is good and another number to treat is bad. For example, you would have when we talk about mammography screening of women over the age of 50 to prevent 1 death from breast cancer in 10 years, the number needed to treat is about 300. 300 women would have to undergo screening every year or 2 to prevent 1 death after 10 years. And that's the order of magnitude of many of the preventive interventions that we use. But in this case, obviously, the number needed to treat is much, much smaller. I want to shift gears now and just talk about the likelihood of future epidemics and review just a little bit about the past epidemics that we've had. Cholera, 1892, of course, there was a worldwide cholera epidemic. 1900, and in fact, cholera continues today, but there were 2 million deaths worldwide in 1892. So, and now the disease ends up being in scattered outbreaks, and without the impact that the old epidemic had in 1892. 1900, there was an epidemic of bubonic plague, and 1917, an epidemic of typhus fever, which is transmitted through the body lice, which are carried by rats, and that came as a result of the First World War. 1918, Spanish influenza, one of the worst epidemics in the history of the world. More people died during the Second World War of Spanish influenza than they did from the conflict itself. 25 million to 100 million deaths worldwide. 1947, smallpox, a smaller outbreak in New York City. 1952, polio was a nationwide outbreak in the United States. 1976, the swine flu epidemic, which really never quite took off, but nonetheless, the vaccination program, which was initiated to prevent that epidemic from taking place, was a bit of a disaster for the CDC. 1982, depending how you date it, HIV/AIDS started to become very common in the United States. 2003, SARS, or which is caused by the coronavirus, and I'll talk a little bit about that, I think, in another lecture. This shows the U.S. mortality rate. You can see the huge spike from influenza in 1917 or 1918 due to the Spanish flu epidemic, but a very rapidly downward trending line from other diseases, other infectious diseases. This is a little bit different line. It has some of the same infections, but it also shows the vaccinations that were instituted and when they were instituted also. And influenza is missing from this graph, so you don't see that big spike from influenza. But I think the thing to recognize here that the epidemics were decreasing much, much more rapidly, and that the vaccination had quite a small effect on the overall reduction. That the large measure the reductions in infectious diseases were due to improvements in overall health and sanitation and in living conditions. That vaccination played a role, but not a huge role in the United States mortality rates. This shows the HIV rates of death particularly from HIV in the red line from 1987 to 2005. And you can see, we'll talk about this more later, but you can see the rapid drop in mortality that started in 1995 for HIV infection, which was due to the institution of 3-drug therapy for HIV, and that HIV has now become a manageable long-term chronic illness. Just to emphasize the difference between endemic and epidemic diseases, we can say that HIV is endemic in the whole world, that it's hyper-endemic, for example, in places like Southern Africa. And when we talk about epidemics, we could talk about a very, very large increase in the number of cases of a disease. So we might talk about an epidemic of influenza or an epidemic of SARS. And I did want to just talk a moment about the iceberg concept of disease. That is that when at the very bottom of this graph, you can see that there's no visual change in illness. You have subclinical disease, so you can have exposure without attachment and or cell entry. You can have exposure without any infection. You can have infection without any clinical illness. And so there are large numbers usually for most diseases of that. And then you get a moderate severity or a mild illness, and you can get a severe disease with death of organisms. So for something like influenza or dengue fever, there are huge numbers of people that have mild or no obvious infections, and then a small number of people at that very top of that iceberg who have either severe or fatal infections. So when we talk specifically about the TB bacteria, we can see that a lot of people, that a high proportion of the infections are inapparent, which is in the white bar, or mild, which is the hatch bar, and then moderate, which is the dotted bar, and then severe, and then fatal in the black bar. Or that if we talk about measles, we can see that most people who get measles have a moderate infection, and some people again have a severe infection and die. And then rabies is almost always a fatal infection. I'd like to now talk about herd immunity. Herd immunity, which I'm sure you've been exposed to. I just want to emphasize a few things about though. And herd immunity exists when a significant portion of a population, originally herd of animals, or in this case humans, is immune to a particular infection. And that immunity provides a measure of protection for individuals who have not yet developed immunity, so that transmission is disrupted when large numbers are immune or less susceptible. And therefore, the greater the proportion of individuals who are resistant, the smaller is the proportion that a susceptible individual will come into contact with an infectious individual. This shows it graphically. In the top cartoon, you can see that the blue individuals are not immunized but are still healthy. The red group is not immunized and sick, and the green is immunized and healthy. So you can see in the top cartoon, there are a few people that are ill and nobody's immune, so then the infectious disease spreads rapidly through the population and affects nearly everybody. In the middle scenario, there are a few people that are immune because they've had the infection before, and a couple of sick individuals, and again, a large proportion of the population becomes infected because of that. In the final scenario, there are a lot of people that are immune, so the probability of one of those people coming in contact with somebody who is not immune is much reduced, and therefore the population is by and large protected from that infection. The conditions that favor herd immunity are when the disease is caused by person-to-person transmission. That is, there's no vector involved. There's generalized transmission to susceptibles, especially in airborne, for example. There's a durable immunity after infection or vaccination, and a high proportion of the population is protected either via prior infection or vaccination. So good examples of herd immunity are smallpox, which was eradicated through vaccination and contact tracing, specifically because it was only existed in humans and was transmitted from person to person directly. Measles, which is still present but uncommon, and an epidemic is not possible when vaccination levels are high. So we generally these days don't have epidemics in the United States, and many other countries also don't, because they have a high level of vaccination. A few years back, we started giving a second measles vaccination to adolescents, specifically because we were seeing some breakthrough measles cases in the university age population. Polio, there's a worldwide eradication campaign with only pockets left in Africa, West Africa, and the Indian subcontinent. Here you can see the polio situation in 1988 versus the polio situation in 2012, so that currently there's only polio in Nigeria and West Africa, and also in Afghanistan and Pakistan and the Indian subcontinent. So one of the questions, an important question is, well, what about influenza? Because influenza is a tremendous concern for a future outbreak. So this was Plans-Rubio's study, and that was published in Preventive Medicine in 2012. This was a modeling study, and it assumes that vaccination would be active against the circulating strain of influenza. Influenza vaccine doesn't prevent all cases, but it does reduce the severity of the cases and also reduces transmission. So this is the conclusion that Plans-Rubio had, and so he says the objectives of vaccination coverage proposed in the United States, 80% in healthy persons and 90% in high-risk persons, are sufficient to establish herd immunity, while those proposed in Europe, only 75% in elderly and high-risk persons, are not sufficient. The percentages of vaccination coverage registered in the United States and Europe are not sufficient now to establish herd immunity. So we don't now have current vaccination levels that are sufficient to establish herd immunity, but the goals of vaccination would, in fact, provide herd immunity against a circulating strain of influenza for which we had an effective vaccine. Some infections are not susceptible to herd immunity. So, for example, tuberculosis, HIV, malaria, typhoid fever, and pertussis or whooping cough are not infections that will be protected by herd immunity. I wanted lastly to talk a little bit about human influenza. Human influenza is a huge concern. If we're going to have another worldwide epidemic of an infectious disease, it's very likely to be human influenza. So it's a disease of particularly concern. There have been 3 global pandemics in the 20th century. And just to review very briefly, influenza is an acute respiratory illness which starts with sore throat, cough, muscle aching, fever, and leads to pneumonia and other severe complications. And there are seasonal epidemics in temperate regions, and there's year-round activity in tropical climates. In fact, it's the southern hemisphere seasonal epidemics that give us a clue about which influenza strain is going to affect us in the following year. So we base our vaccination every year on what was happening, what was circulating in the southern hemisphere during their winter. The U.S. impact, I'm a little skeptical of these figures because our surveillance data for the U.S. doesn't really differentiate between influenza and pneumonia. At any rate, there are said to be an average of 200,000 influenza-related hospitalizations per year and an average of 36,000 deaths of influenza per year in the United States now. I just want to talk a little bit about the key influenza viral features in order to be able to understand the terminology that you use. You need to just understand that when we talk about influenza strains, we talk about two surface proteins or major antigens on the surface of the virus. There's the hemagglutinin, or the H antigen, which is the site of attachment to host cells, and antibody to hemagglutinin is protective, and neuraminidase, which is abbreviated as N. It helps to release virions from the cells. So the subtypes of influenza A are based on those surface proteins, hemagglutinin and neuraminidase. So the current human influenza vaccine subtypes are primarily H1N1, H1N2, H3N2, etc. And the influenza viruses affect multiple species, not only humans, but also wild and domestic poultry and other animals, particularly pigs. The 1918 through 1919 Spanish flu epidemic was an H1N1 epidemic, and it was most deadly, in fact, for people between 20 and 40 years of age. And as I mentioned recently, it caused more deaths than from conflict in World War I. And half of all U.S. soldiers who died in World War I died of influenza. Influenza viruses are susceptible to two things. The first thing I want to talk about is antigenic drift. So these are point mutations in the virus which cause minor antigenic changes to the hemagglutinin surface protein. It's a continuous process, and immunity against one strain may be limited. That's why vaccine strains must be updated each year. It's a 6 to 8 month process to do that, and it's targeted high-risk H antigens, which are seen in the southern hemisphere that year. So antigenic drift is what causes seasonal epidemics. Antigenic shift, on the other hand, is what we're really concerned about, and that's the emergence of a new human influenza A virus subtype. That is a new H or N subtype through genetic reassortment, either in animal or human viruses, or direct animal to human transmission, that is bird flu. Because there's little or no immunity to this novel virus where there's been an antigenic shift, a worldwide epidemic can occur if there's efficient and sustained virus transmission among humans. This slide shows the scenario for a possible antigenic shift pandemic of influenza A. It happens when human viruses and avian viruses reassort within another animal, in this case a pig. And so the virility factors of the avian virus meet with the human factors which allow human-to-human transmission and result in a highly virulent virus, which is also transmitted between human beings after reassortment. Avian influenza, then, A viruses are very concerning. They infect the respiratory and GI tract of birds. They usually don't cause disease in wild birds. However, the genetic reassortment occurs frequently, and they can cause morbidity and mortality, especially in domestic poultry, which is why there have been so many mass slaughters of domestic poultry in the last few years when they have been infected with avian influenza. And they're shed in the respiratory tract and in the feces of birds. They can survive at low temperatures and low humidity for a while. They can survive on surfaces, so disinfection of the environment is needed in order to prevent the viruses from reinfecting any new flock of birds. In 2003 to 2006, there was a large epidemic of H5N1 avian influenza in poultry in Asia. Farms, backyard flocks were affected, and millions, about 100 million birds were culled. 9 countries reported H5N1 poultry outbreaks, and in 7 countries, transmission has continued, and control is unclear. This shows the outbreaks in Asia of the H5N1 virus in 2003 to 2004. Poultry workers are particularly at risk. Infection is uncommon, but when infection happens, it can be very, very significant or lead to death. And so we've continued to have small numbers of avian viruses, virus infections leading to death. But we have not yet seen the reassortment or genetic shift that would now allow those viruses to be transmitted from person to person. So there were 42 deaths in the 2003 to 2005 outbreak, and avian influenza has continued since that time, but there have been occasional deaths, and there's been, again, no extensive person-to-person transmission. Most cases had contact with sick or dead poultry. The majority of cases were children or young adults, and the viruses, unfortunately, were resistant to antiviral drugs. So that human infection with avian flu has resulted in mild to severe illness, including deaths, but there's no current evidence of sustained person-to-person transmission. And the key to preventing future outbreaks with avian influenza A is to control poultry outbreaks rapidly, to detect them and control them. The public health impact of the viruses, a future influenza pandemic in the U.S. could result in up to 200,000 deaths, 500,000 hospitalizations, etc., with a huge economic impact. So, and it could affect 15 to 35% of the U.S. population. So influenza pandemics are a severe concern for the future. We'll be talking later when we talk about emerging infectious disease, about SARS and MERS and so forth. But I did want to put in a word about influenza during this lecture. And this is the result of an avian influenza outbreak with a bunch of pink flamingos. And that's all for today. So good luck on all your projects, and I'll talk to you next time. Bye-bye.